I think you may be muted.
Thanks, Elliot. Next, I'd like to introduce Dr. Ruth Carrico from the University of Louisville School of Medicine. Ruth has broad infection prevention and control experience, broad research experience, and is an expert in environmental decontamination. So Ruth, I'll turn it over to you.
Thank you, Kathy. It's a delight to be here, and it's a delight to follow Adriana giving an overview about some of our current challenges, and then to be able to proceed both the discussion about ventilation that was briefly touched upon, and then talk about some of the existing guidelines as a reminder that despite our dealing with the pandemic, we cannot let loose of our basic practices that form the foundation for safety as we deal with this pandemic around the world. The next slide. So in our few short minutes today, I'm going to spend just a bit of time reviewing just a tad about what we currently know about this virus and its vulnerability to our current germicidal agents. Then what are some interventions that we are looking at for environmental infection control of surfaces? And then what does this mean to healthcare worker safety and the impact on the workplace? And then end with just a couple of emerging questions. Next slide. Fortunately, we have learned that even though this virus is ferocious when it's inside our body and causing illness, conversely, when it's outside our body on surfaces, we have a greater opportunity to impact and with our usual approaches be able to address this virus and render it helpless and ineffective. So in the US, we rely on guidance from the Environmental Protective Agency, the EPA, and they provide then some guidelines for us to think about with when we are thinking about protection and appropriate use of materials. So the Environmental Protection Agency, EPA, has a what is known as List N that has lists of the particular germicides that have met the criteria for addressing emerging pathogens. Fortunately, these microorganisms and these germicides are the ones that we typically use in the healthcare setting. But we can go to the EPA.gov website and then check on that list and then get information about some of the specific liquid germicides that we have available for disinfection. We have learned that this microorganism, again, it does live on surfaces, but not for extensive amounts of time. Certainly, if you have something that's on a surface for days, that is problematic. But fortunately, using our germicides that are typical for healthcare, we can address this. And this has been outlined, as Adriana mentioned, that we have a very nice discussion about this from the WHO document regarding cleaning and disinfection of environmental surfaces. And then we've had some very nice reviews and some excellent research that has come out of Germany. And there have been a number of, I love to read the German studies. They are so well done, so well written, and very focused and timely on dealing with COVID-19. So we have an organism that, yes, it's problematic, but yes, we can address it with the routine germicides, including the ones Adriana mentioned, the sodium hypochlorite and the 70 to 90% alcohol. Next slide. We use then a number of our traditional methods for cleaning and disinfection. We certainly use the pop-up wipes, the ready-to-use wipes, but in the US and I think around the world, we have found that, you know, our supply chains are unreliable, that we tend to have, we go from feast to famine, that we will have enough and then we will find out that our pipeline has been interrupted and we do not. So as a reminder, we go back to oftentimes our tried and true, which is we use a cloth and a bucket of germicide. And if we use cloths, then we've learned from our research that microfiber provides us with excellent benefits. We just have to handle those cloths correctly. We've had a number of other mechanisms for environmental disinfection that we have begun to not only learn more about, but in some cases become more reliant upon. One of those is the use of UV radiation. Whenever you use any type of technology, it's important to note not only its benefits, but understand its limitations. So it's a reminder that the physical, mechanical activities of cleaning and disinfection are going to be very hard to beat, but we may use adjunctive measures or additional measures, such as spraying of devices, or as we have seen, the use of some types of disinfection to actually help us prolong the life of pieces of personal protective equipment. So a number of facilities have used hydrogen peroxide vapor and UV to decontaminate respiratory protection. So the environmental interventions can address not only the surfaces of our medical equipment, but also surfaces of the reusable medical equipment that we may end up moving from patient to patient, and also help us with our personal protective equipment life. Next slide. Whenever we have any intervention, as I mentioned, we always have the positives, and we have the limited and sometimes limitations, and sometimes we have the unintended consequences. So anytime we use any type of intervention, we need to make sure that it is safe for the workers. And I think COVID-19 has reminded us that we have got to protect our healthcare workforce at every step. That if we do not protect the healthcare workforce, that not only will we not have enough workers to deal with patients with COVID-19, but we will not have enough workers to address the traditional and the never-ending healthcare needs that occur in society. Women that may need medical care during labor and delivery, the person that has a myocardial infarction or stroke or a traumatic event will still need healthcare. And so without safe and healthy healthcare workers, society has very difficult challenges to function. So just quickly looking at this table, our liquid germicides, if we use them according to manufacturer recommendations, generally it's limited to skin protection from contact and then eye protection from splash. Very limited exposure opportunities if we use that type of personal protective equipment. Once we begin to move up the chain and start using then technologies that bring in not only new opportunities, but new challenges, we have to be thinking about the protection. So for example, electrostatic sprayers now have really hit the worldwide market in providing a vapor of germicide. With that vapor is some sort of pressure, which means that we may need to reconsider the type of respiratory protection. In the United States, the Environmental Protection Agency, the EPA, just put out a couple of statements now regarding what type of respiratory protection should be used. And so we may be looking at that as being a potential respiratory issue for the healthcare worker using that device. For UV radiation, we know that many times we call it UV light. It sounds less problematic than UV radiation, but it is radiation, and therefore exposure to the eyes or to the skin can be a difficulty for the healthcare worker. If we use vapors such as hydrogen peroxide, and we may be using that to disinfect personal protective equipment or use that to disinfect the environment. Again, we have to worry about the actual vapor and inhalation and what the impact of that is going to be on the user. So I go back to, at the very end of the day, remembering that let's make sure that the intervention is aligned to the risk. So we have an organism that we can kill with our traditional germicides. As we become more complicated and with our additional interventions beyond the routine, what we call elbow grease, just the soap and water cleaning, and then following disinfection or using a combination product. Once we get away from that, then we have increased risks to the user and increased complexities, and many times increased cost as well. Next slide. As I mentioned, then the healthcare worker, then we've got to make sure that we are equipping individuals who are going to be cleaning the environment of the room and of the patient room, and then remembering how are we going to do that. And our CDC guidance is reminding us that if the patient is still in the room and they are a COVID positive patient, then we want to try to prevent direct inhalation as part of the care of that patient. And we generally consider patients that are requiring hospital care to be patients that are most infectious and therefore have the highest, potentially the highest viral load, and are able then to transmit the infection perhaps more efficiently. So that's why we say in patients with COVID in the hospital, in the healthcare facility requiring care, we want that higher level of respiratory protection. After discharge of the patient, environmental services that is still in the room, they wear their protective equipment according to the instructions for use of the germicide, and those are outlined on the safety data sheet or the material that is made available by the manufacturer. We have to think about the airflow, the ventilation that is in that room, and most of us that have worked in infection control have become familiar with Table B, and I put the link there, and this is the table that gives you an idea about whatever the air exchange is within that environment, how long it takes to remove virtually all of any airborne or floating particles that may be in the room. So how long you want to wait before you enter that environment. And the basic rule of thumb in infection control has been we close the door, we wait about 30 minutes, and then we should have had some sufficient air exchange to remove the likelihood of inhalation. Now, not direct contact with the surface, but I'm speaking just direct inhalation. Now, we've had much attention currently, and I think Marie will talk about this shortly, about what are we learning about the air and the actual airflow and its relationship to transmission. And I would just say, you know, it is important for us to look at what is occurring in practice. When we look at what happens in the laboratory, we can develop all types of scenarios, but we have to be very focused on what are we risking and what is our potential contact in the real world environment, whatever that real world happens to be in the building or the setting. We don't currently have any risk indication that there is increased risk of acquiring COVID among environmental services personnel or those that are cleaning the environment. But it's a reminder that unless we report data, we don't have data to review. So although we don't have information about increased risk, that there is the thought that most of the healthcare transmission that is occurring, at least that is reported occurring, and this is primarily, I'm speaking of data that we have in the US, that with protective equipment, we are not seeing transmission among healthcare workers or patient to healthcare worker when protective equipment is worn. But we are not seeing that those that clean the room have a greater likelihood of illness. Next slide. So just in bringing this, getting near our close, the virus and community surfaces we are looking at more heavily, and looking at what is involved in community-based transmission. We know that if we use traditional disinfection in the community, that we should be able to address this in the same way that we do in healthcare. However, we know that we are seeing a lot of glove use in the community, that people feel like it's safer for me if I wear gloves. But just remind that people who wear gloves tend to wear them instead of performing hand hygiene. And anyone in infection control, we have a particular love and respect for clean hands. So glove use in the community is problematic because it is often, again, in lieu of hand hygiene. We know that we have questions about cleaning restrooms, and now that we have data, we know that we're finding the virus in stool. And I think a number of studies, I think I read one recently in Italy looking at public sewage and using that as a marker for presence of disease in the community. So does that mean we need to pay attention to cleaning of public restrooms? And there may be opportunities for engineering interventions at that in those areas. We know that we have presence of disease in any type of congregate setting, specifically prisons and jails. So whatever our mechanisms are for environmental disinfection, these are our future patients. So we need to remember them, as are potentially the homeless population. We don't have a lot of data yet about that, but we do have reports of disease transmission in shelters. So whatever we do in healthcare, we need to keep an eye on the community. And overall, we're hampered by our ability to have enough tests available. If we can't test for presence of disease or where disease is located, again, it's hard for us to use resources appropriately. And I think this is a problem certainly around the world that challenges us in understanding the true incidence and if there's any geographic information about the presence of the virus and disease. Next slide. So I put together then a list of resources that I hope will be helpful, that people will be able to go back and refer to as we continue to figure out where is this overlap between healthcare, engineering opportunities, innovation, and patient protection. So with that, let me turn it back over to you, Kathy. Oops.
Thank you, Ruth. Dr. Carrico will remain with us through the Q&A period. So if you have any questions for her, you can submit those via the Q&A button at the bottom of your screen. Next,